Hi, good evening. I'm Dr. Gary Howsam. I'm Vice Chair for External Affairs at the Royal College of General Practitioners, and I'd like to welcome you all to the next in the series of live panel debates that we've been holding at RCGP for our members. This week, we're going to be talking about the future of general practice post-COVID-19. You can put any questions you have for the panel to us at hashtag RCGP Together Live on social media, or you can write them in our online member forum. If you haven't watched one of these sessions before, the idea is to bring you senior leaders from across the college to be able to speak to you directly about what the colleges have been doing over the last few months and what we're working for on behalf of you and our patients. I'd like to start this evening by introducing the panel. We have Dr. Lawrence Dorman, Chair of the RCGP Northern Ireland Council, Dr. Mayor Hopkin of RCGP Wales Council, Dr. Alistair Forbes, Vice Chair at RCGP Scotland, and our Chair of UK Council, Professor Martin Marshall. So onto the topic. We all know that general practice is on the front line of the NHS, and the way in which we've been delivering services over the last few weeks and months has changed dramatically. This has allowed us to support our patients in a time of national crisis and using different tools and technologies in order to make sure that services of a high quality and safety are maintained. COVID-19 has, however, exposed the vulnerable parts of the health system, and it showed us that health is about more than just providing good healthcare. General practice is at the heart of our communities, and it's key to community working that will support the long-term health needs of the UK and to help to pick up the pieces in the aftermath of this terrible disease. The college has been carrying out a number of engagement exercises with members and patient groups, looking at some of the positive changes that have taken place over the last few months in terms of the way we're working, and has been asking questions about the sort of things we'd like to maintain and the sort of things that we need to reset and change as we move forwards. You'll be hearing a lot more about this next week as we celebrate the NHS's birthday with the launch of a report on this and a campaign that will be hitting your inboxes shortly. We'll be using this report to look for change, to lobby government, to influence stakeholders. So what I'd like to do now is move on and ask each of the panel members if they could just briefly introduce themselves, maybe tell us where they are this evening, where they work in general practice and what their role within the college is. If I can go to you, Martin, please.
Thanks very much, Gary, and thanks to everybody for joining this webinar. It's great to see you, or not to see you, as the case might be. I'm Martin Marshall. I'm Chair of the College. I'm a GP in Newham in East London, and I'm a researcher at University College London.
Okay, thank you, Martin. Mayor.
Hi, I'm Joint Chair of RCGP Wales. I've been a GP in Pontyclun in South Wales for 32 years until last year, and I still work with Health Education Improvement Wales and very involved in GP training.
Okay, thank you, Mayor. And if we go across to Northern Ireland and Lawrence.
Good evening, everybody. My name is Lawrence Dorman. I'm coming to you from Market Hill in Northern Ireland, and I'm a GP in Kilkeel. Kilkeel is a small fishing village on the eastern coast of Northern Ireland, down by the Mourne Mountains. It's a pleasure to be with you all tonight.
Excellent. Thank you, Lawrence. And up to Scotland and Alistair.
Hi, I'm Alistair Forbes. I'm a GP in the Bridgetdon in the north of Aberdeen. Our practice area includes Mr. Trump's mini golf links, so he's a sometime temporary resident. And I've been a GP here for 26 years. I'm the Deputy Chair of Policy of RCGP Scotland.
Okay, thank you, and thank you all for joining us this evening. Martin, I wonder if I could come to you to start with, please, just to talk us through the broad themes that will appear in the report and what the college will be calling for in the post-COVID context.
Yeah, thanks very much indeed, Gary. So I think everybody recognised that when this crisis came along, general practice changed, adapted very, very quickly. And the longer the crisis went on, the more likely it was that those changes were going to be ones that would be embedded to a greater or lesser extent in the way that we work in the future. And that, as Gary said, is what we've been working on as a college. There were a lot of areas that we heard from our members that were potentially important, ones that we definitely wanted to keep as part of the delivery model of general practice, ones that perhaps we wanted to think about, maybe adapt, and ones that we really wanted to get rid of when the crisis was over. So in our engagement exercise with a wide range of members, we talked about all of those areas. What we've done as a college is tried to focus on 3 areas that we think we can get most traction on by using our influencing ability as an organisation with our political and policy colleagues. It's worth remembering that we're not rewriting the vision of general practice. We have our vision of general practice. We have a collective one for the college, which was agreed last summer. It's called Fit for the Future, and each individual devolved nation has its own vision as well. What we do want to do, though, what we saw COVID doing, was giving us an opportunity to essentially implement that vision more rapidly than would have happened without the crisis. So the three areas that we focused on are 1, technology, 2, workload, and 3, a public health model of general practice. So just very briefly, the technology focus is around obviously the use of technology for remote consultations, also the use of digital triage, and the use of technology to improve interface working, particularly with consultants, and perhaps 3-way digital consultations with patients as well. So that was the technology area. The workload area, many GPs I've spoken to have said that they've kind of refound their mojo as a consequence of this crisis, which sounds really odd, but a lot of GPs have said what felt like an undoable job, working at 130, 140% of their capacity to deliver a good job, is now down to 100% or even slightly less than 100% at one stage of the crisis. That's given them space. And the way that's happened is partly by reducing clinical workload, 24% down at the crisis. That has some good and some bad features, but mostly by a reduction in administrative workload. It was down 30% according to data from our research surveillance centre. So the question is, how do we continue and embed those changes? So that's the workload area. And then finally the public health area. This is about, in many ways, reinvigorating the public health model of general practice. We recognise we have a biomedical model, a psychosocial model, and a public health model. The public health model is perhaps the least well developed. This is about populational health planning. It's about dealing with health inequalities. It's recognising social determinants of health and social interventions. It's about building on community assets. And that's an area that we want to really push and encourage people to think about how they can embed that into their daily practice so we can serve our patients and our communities most effectively. So I hope, Gary, that's a useful introduction.
Yeah, that's great, Martin. Thank you ever so much for highlighting those 3 broad areas. Just to remind people, if you want to pose any questions to the panel tonight, you can go through #RCGP Live Together on social media or the website's online members forum. I'm going to move up to Scotland and Alistair and just ask you, I mean, Martin's talked about the changes, but also there's been a remarkable pace of change. Any changes in your practice at all? I understand you've started using e-consulting.
Yes, thanks, Gary. Yes, we were looking at this, as all practices do, doing trips to practices who were actually using it and considering it, chewing the fat. And then COVID hit. And after doing 2 or 3 weeks of exclusive phone triage with some near me video consulting, because that was quite quickly adopted locally and throughout Scotland, we realized that it wasn't sustainable as the workload started to creep up. And we all found that phone triage was not what we were used to. It was actually long phone conversations. It was quite exhausting. So we decided that we would adopt electronic consulting. And within a couple of weeks, we went for it, and we have been doing it for 3 weeks now. And our patients have taken to it very well. We have done almost 400 e-consults in the last 3 weeks. And that's from a standing start of 0. And we have had no positive advertising yet. We decided to do a soft launch. We've had our staff making suggestions to patients when they phone in. And we're getting currently almost a quarter of calls some day being converted to e-consult, which has been very useful. And the one thing that has struck me, if you'd asked me in January, would I be saying that e-consult is a good medium? At the beginning, I would have said no. And actually having used it, all my concerns about lack of continuity, not being able to have the sort of personal touch, has actually been allayed. I have found it's actually been very useful. I am now telling my patients, why don't you send me an e-consult in a few weeks' time, tell me how you're getting on. And that enables the continuity, and it's much quicker, because I'm sure we're all now very familiar with the problems of trying to contact our patients on telephone, almost always by mobile phone nowadays. And they're often walk into an area that they tell you, oh, I'm sorry, I'm driving, or I've just walked into the shop, or they've got into a black spot and they have to be called back. And it is quite frustrating for everyone. So actually, the electronic gateway, as we're calling, or a digital gateway, has been very useful. The thing that has to be kept in mind is, of course, there are patients who are not able to use this. And these patients, we should always accept that we can't get 100% of patients all the time. So we're quite happy to use more traditional methods of contact for those who are not able to do it. But the last e-consult I did yesterday before finishing was for a chap who was 80 who found it no trouble at all. So there isn't a problem with the silver surfers. Though I have to remember our population that I serve is predominantly middle class with virtually no deprivation. Our joint practice that we also run has had a soft launch about 10 days ago, but much higher levels of deprivation, and uptake has been significantly lower. So that there is certainly something that we have to make sure that we have good digital infrastructure that is equitable. And we know that there's problems if you're in more remote and rural because of that, or also areas of urban areas with high deprivation. But overall, I've been surprised by how good it is. And certainly our hospital consultants are also using Near Me and enjoying it. And so far, patients on the whole seem to like it.
Excellent. Thank you for that, Alistair. So I'm going to move over to Northern Ireland. And when we've engaged with our members, Lawrence, you know, some people have concerns around technology and the use of telephones and this concern around call centre medicine. But others are really enjoying the flexibility, being able to schedule callbacks with their patients and just to being able to arrange their time. Have you had any feedback from your membership in Northern Ireland around any particular aspects of the technology that you've been employing over there?
Yes, Gary. So in Northern Ireland, we've been quite similar to Alistair in that practices over here hadn't done remote working to the greater extent that we see now. And literally within a week, all practices in Northern Ireland turned to a total telephone triage system. And speaking to our colleagues here, a lot of them really like it. Myself included, I mean, my practice didn't do much telephone triage, and we always said that we would trust the patients and let them make their own appointments and so on. But we've been pleasantly surprised, and actually more importantly, so have our patients. I'm just off a call for one of our patient groups there tonight, and they've been feeding back their experiences of remote consultations, and they particularly have enjoyed the telephone consultations. They found them low tech, so to speak, very accessible, and the ones that they really liked was whenever it provided a seamless service. So be that a phone consultation from a GP, which led on to maybe an investigation being acted on quicker, which led on maybe to a prescription being delivered straight to a chemist much quicker. They've really liked that sort of seamless service of it. So actually our patients are giving us really good feedback from it.
Excellent, thank you. And then Mayor, if I can come across and ask you a question around some of the technical issues that we struggled with at the start, maybe. If we're going to use the technology, first of all, we've got to make sure that everybody has access to the kit and to good broadband and things. Did you have any particular problems in Wales that you encountered and that you were able to find solutions for through your college lobbying role?
I think the access to broadband is a big problem because a lot of our patients and many of our GPs have very poor broadband access. And if we're going to move to a more digital way of working, then that needs to be addressed. And that's something that we discussed with the government today in Wales, was how we can improve broadband access. We had initially some problems because there was very little e-consulting going on in Wales. There was quite a lot of telephone triage, but not very much e-consulting, and certainly not very much video consulting. Some of our members were a bit upset at having to pay to have a VPN in order to access, be able to consult from home. But it wasn't very long then before NWIS, the technology service in Wales, managed to roll out Access Anywhere. And that's been a great help. A lot of practices have engaged with more commercial organizations such as AccuRx, and we're trying to get an improvement to Access Anywhere to make it a bit more usable for GPs and to do some of the technological things that some of the commercial consulting bodies can do.
Excellent, thank you, Mayor. And I think you've just touched on there, one of the really important roles for the Royal College and our various councils across the devolved nations is this lobbying with ministers and with governments. Now there's elections coming up in Wales and Scotland next year, I believe. Alistair, are there any particular things around this technology that you'll be lobbying for as you'll run up to the election and as you prepare your college election manifesto?
Certainly, one of the things that we are looking at, and what I've touched on, is this the importance of good broadband infrastructure. There is no problem if you're in an area like I'm in. I say in a small village just to the north of Aberdeen, and we've had super fast broadband for a number of years. However, there are areas even in the centre of Aberdeen, and also just if you go down into the more rural areas of Aberdeenshire, and then north and west into the Highlands, where you have almost no broadband, and you also have no mobile phone signal. So therefore, we do need to focus on getting good technical infrastructure and good IT infrastructure, because we haven't touched on that. The IT is a significant issue because we don't have interoperability of systems. And in Scotland, we're working with health and social care partnerships and more cluster working, but GP systems don't speak very well to primary care systems, and social care systems don't speak. So we need to have a more integrated IT system to enable us to use care, to do our job better for our patients, and help the interfaces both across the community and also between primary and secondary care. Another issue, as one of my roles is chair of the GP Recruitment and Retention Advisory Group in Scotland, is if we're trying to recruit GPs to come into areas, particularly remote and rural, where just now there is still a problem where we have many areas covered by just advanced nurse practitioners rather than GPs. If you've got good broadband, then you've got more chance of getting young families to settle because they're not put off. We have people who are now used to streaming things. They don't want to watch TV as an event. They want to watch a program at their choice of time. If they can stream things, that's great. If they can't, you're asking them to undergo a huge lifestyle change, and that puts rural areas at a significant disadvantage. So we do need to have proper IT investment, both in the software as well as the digital infrastructure.
Okay, thank you. And one of the things you touched on there was sort of technology across organisations, but I think one of the other reflections I've had, certainly working within a fairly large practice, is that the technology's provided opportunities for us to work with our teams in a different way as well, because often you go into the practice, you're sat in your surgery for 12, 14 hours a day, and you don't have that contact with the team. And we know that as we're working remotely now, lots of people working from home, we've had to use the technology to make sure that we keep team cohesion and we can support each other. Martin, have you found any ways that you've used technology across the teams that you work in to your advantage during this period?
Yeah, very, very much so. You know, the concept of digital huddles, getting together through Zoom type conferences, supporting each other on a regular basis, that's been phenomenally useful. Also, actually, team meetings, you know, the kind of weekly meetings that traditionally we would have had face to face. They've always been a bit of a problem for part-time GPs. I'm a part-time GP. The opportunity to be able to dial into those meetings on a day that you might not be in the practice has really helped everyone to feel part of the wider team. So I think there's many ways in which we could use technology to improve team working in general practice. I think that's really exciting.
Okay, thank you. And Lawrence, any reflections from Northern Ireland on that same issue? Because I think you've been providing sort of care for COVID patients in a slightly different way to over here in the UK with your COVID hubs. Is that right?
Yeah, that's right, Gary. So, I mean, just as Martin said there, I mean, it's been invaluable for getting the practice teams together. And also remote working has been really important because we've had many GPs who've been shielding during the COVID crisis. So they've still been able to play their part in the workforce. You're quite right. In Northern Ireland, we separated our hot from cold, and we established COVID centres, and those were established to help provide an environment where patients could be assessed safely, protecting GPs and protecting their practice teams.
Okay, thank you. So before we move on from this area of technology, I was wondering, Martin, obviously one of the aims of the paper that went to council and the report that we'll be publishing next week was to highlight our calls for ministers, for governments. If you'd just like to summarise what the college is actually asking for in this arena of technology as we move out of the COVID crisis.
Yes, there's a number of areas where we've got specific asks of policymakers in all 4 nations. One of them we've been touching upon is internet access, making sure that we've got good broadband, so that we can get the kind of care that we need online. Another one is equipment, for example, in my local CCG has bought a whole load of laptops. They've given them to GPs who want to work remotely. That's enabled a larger workforce, which has been incredibly useful. The laptops have got all the software preloaded, so even if you're not particularly technically enabled, it's very easy to use. We've got simple VPN connections, which ensure safety. So we've been asking for that to make sure that that investment, which in some areas has been better than other areas, to make sure that that investment continues as well. So there's a range of areas. Training as well is another area where we really want greater support. Some of the online providers, which I have to say haven't been particularly popular, often with good reason for general practice, have nevertheless been very good at training their staff. That isn't necessarily something that we've done particularly well across the wider NHS, with a few exceptions locally. So I think better training is another area. So there's a range of specific asks, and our impression in England, colleagues in devolved nations will be able to give their experience, but our impression in England is that government are really very receptive to the asks that we're making.
Excellent. Okay, and I think particularly for the devolved nations, there's been an ask around the rollout of e-prescribing. Mayor, any comments on that, please?
Yes, this is something that we were pushing for pre-COVID, and obviously it would have been wonderful if it had been in place at the time of COVID. We think it's got big implications for patient safety and for patient convenience, because at the moment patients have to pick up a physical prescription, or it has to be physically sent to the pharmacist. We did speak to the health minister today about it, and the Welsh Government is undertaking a rapid review of what's available. We're keen that it's run out in general practice as soon as possible, but it looks as if the Welsh Government is holding out for a system that will be useful across the piece, across primary and secondary care. So we might have to wait a little bit longer, but we will keep asking for it.
Excellent. Okay, thank you. I'm going to move us on to those second of the areas that you were talking about, Martin, and that's around workload. I know that reduction in workload is one of the areas that you're passionate about, because you believe if we can free up GPs to spend time caring for their patients and cutting down some of the bureaucracy and the administrative work that we have to do, then that's got advantages for everybody, both in terms of the workforce and more importantly for our patients. So can you just outline quickly what the main asks are for around that, please?
Yeah, so there are many aspects, particularly of administrative workload, that we could be asking for action on. In order to be effective, we tried to focus on a small number of areas. The first one of those is basically contract compliance. So in England, that would be QOF. It might be different in other countries as well. But a lot of time is spent being held to account and filling in boxes and ticking boxes in general practice, and that can be deeply frustrating when you want to spend your time doing what we've been trained to do, which is look after our patients. So we're asking for a different kind of system of what we call high trust contract compliance, where basically you trust people to do the right thing. The vast majority of GPs will, because that's what we're trained to do and that's what we want to do as professionals. So there isn't any need to be constantly checking. It's quite radical in an environment in which we've become very used to checking, but again, we seem to have quite a receptive response from government to shift into that kind of response. So that's contract compliance. The second area is around regulation. Again, this is particularly an issue in England, but it is an issue in other countries as well. In England, we have significant regulation through CQC. We're saying that other countries within the UK and other countries outside the UK have not got regulation, and they seem to provide as safe care as we provide. So what is the role of regulation? We know it can be really important for some practices that are struggling. But actually for the vast majority of practice, our argument is it's disproportionate. It doesn't add value, and indeed it gets in the way. So we're asking for the release of regulation, which has happened during the COVID period, to continue in the post-COVID era. And then the third area is around appraisal. Now, many people engage with appraisal. Appraisal should be a good professional development, formative opportunity. But increasingly, we've created a little bit of a monster in many ways. It's become quite bureaucratic in some countries. Again, a lot of box ticking. I spend probably about 4 or 5 days a year preparing for my appraisal as a part-time GP, and I just wonder how much that preparation adds value when, again, I'm ticking boxes. The meeting adds an enormous amount of value, and what we're saying is a much shorter preparatory form with a supportive, helpful meeting. So we're working through Susie Caesar, who's our appraisal lead for the college, with the GMC, with other college across all four jurisdictions in order to implement this system. And GMC have been very supportive. We've got a form which should take somewhere between 30 and 60 minutes to complete, a preparatory form, and then we can really put all our efforts into the face-to-face meeting with the appraiser, which is where we think it adds value. So those are the three main areas that we're working on.
Brilliant, that's great, thank you very much. And I think one of the things that we mentioned earlier on this discussion was that the jobs felt more doable for an awful lot of our members across the 4 nations. So I'm going to go up to Scotland and ask Alistair, if I may please, what change in regulatory burden have you seen that you think's had the biggest impact and that you would like to sort of control its re-emergence again after the situation changes going forwards?
Well, we had the advantage of being able to move away from QOF a few years ago now. But I suppose a lot of it has been the non-essential paperwork that we have been asked to do that is not core GMS work. But these are beginning to creep back in again as things are beginning to come on board again. And it is things that are perhaps better done by people like occupational health physicians, the reports that we're asked to do, and working in an area where we do a lot of informal occupational medicine because of the high number of people who work offshore and overseas. We don't have ready access to offshore because to accompany occupational health doctor, we get a lot of occupational medicine requests locally. But it has been great not to have to go through the QOF box ticking exercises. And I don't think care has particularly become bad overnight in Scotland. And at RCGP Scotland, before COVID, we were looking at what should quality look like in a post-QOF world. And we're doing some work at, for example, how to improve access for patients and good patient care. So having, as Martin's alluded to, a high trust is, I think, a very good way forward, because when people feel that they're trusted and valued, they do better. If you ask any good manager, no matter what the industry, they know that is a fundamental to get good staff engagement. And it's just the same for us as independent contractors. If we're trusted, we will do the job and do it well.
Okay, thank you. We know that one of the things, certainly in England, that people will often quote as feeling a regulatory burden is the preparatory work and then the inspections around CQC. Now, I know in Wales, Mayor, you don't have CQC, do you? So what system do you have in Wales, and how does that work, and how do you think that feels different? And anything you'd want to change in the system that you've currently had that's maybe altered over the last few months as well?
Yeah, we have Health Improvement Wales, and last year the BMA and RCGP Wales had the first meeting for a very long time with Health Improvement Wales to try and find out exactly what the problems were in general practice. The inspections don't seem to be quite as intrusive as I've heard CQC is. And we found that the meeting was very constructive, and we all have the same aim, and that's to practice safe general practice and to make sure that everything is safe for our patients and for our employees. So we were very pleased with that discussion, that there seems to be a way forward, and we found that most of the things were simple things like having the equipment for resuscitation, and those are things that we can promote as RCGP Wales.
Okay, thank you. And Lawrence, over to you in Northern Ireland. I mean, governments in every nation surely should have an action plan as to how they can reduce workload burden around bureaucracy and contractual burdens. What would you want on your government's action plan going forwards?
Well, so we still have QoF here in Northern Ireland, and as Martin and Alistair has alluded, the big issue of trust has come back into GPs here. It's been a big thing, and we had a big open roadshow with our members a couple of weeks ago, and it was incredible to hear how many GPs in Northern Ireland have started organising themselves to target patients who need their help the most. This is diabetics whose control is getting out of hand, asthmatics who could be particularly brittle, and they've done this not because they've been sort of mandated to do it, but because they know it's the right thing to do and it's the right medicine to do. So things that add value to that and prioritise people, I think, will be very important going forward.
Okay, thank you. And we know that we've started to see the QoF QI quality improvement programs established over the last 12 months across some of the 4 nations. And that sort of regulatory burden, if it's focusing on quality improvement rather than just ticking boxes for process sake, that's got to be a good way forward. Alistair, have you got any other comments around how you think we can reduce that tick box mentality? Because that paradigm shift to high trust of professionals to do what they should be doing for their patients, to me, appears to be the core of what we're asking for.
Yeah, well, one of the things that I think could move away from that is if you have a practice that is a recognized training practice with people who are recognized trainers, they've already undergone a pretty rigorous external assessment of their abilities, not only as a GP, but also as a teacher. And that should be an indicator that a practice is actually committed to a culture of, if you like, striving for excellence. And I think that would not only incentivize people to become trainers and educational supervisors, but you get a framework whereby if you're doing that, you say, well, they're safe and they're doing it because they're checked regularly by other people. And then you could then use resource, rather than trying to visit everybody, you could then use resource on helping people who are struggling for a wide variety of reasons. That would be far more sensible. And this is part of the high trust, but also taking away the perceived punitive elements of this and turning it into a far more supportive thing, which is actually would benefit everybody rather than creating headlines about a bad doctor or a bad practice.
Okay, thank you. Mayor, I'm going to come to you and ask you about appraisal. I think my experience is, again, I'm a part-time GP, but it does take a whole week of evenings to do the preparation for my appraisal, which really is the burdensome bit. The actual conversation with the appraiser is really useful, both reflecting on the year that's gone and also planning for the year ahead. What elements of appraisal do you hold dear, and how do you benefit from the appraisal process that you go through?
So in Wales, we're lucky really, because appraisal has always been in the realms of education. And so it's always been an educational activity. And I've always found it very supportive. I find having the conversations with the appraisers over the years have become a little more stretching. They've become a little more probing, but they've always been supportive and they've always been encouraging. We have an electronic system which has been in place for many years now, and that's called GP Mars. One of the advantages of that is that it's available anywhere that you can get access to the internet. So if something happens and you think, oh, I must remember that for my appraisal, you can log on to the internet and start putting an entry in there. A lot of the background information, so things like what inhibits our learning, what are the constraints to our personal development, are available on a tick list. And I know you don't like tick lists, Martin, but the advantage of that is that the information can be collated anonymously, and then Health Education Improvement Wales can look. And if in an area you find that hospital referrals are the thing that's holding you back in your personal development, then educational events can be arranged around that. So it's a very integrated service, and I've always found it very supportive. And I don't find the electronic system particularly burdensome. It's just remembering where I've put my certificates so that I can scan them on when the time is ready.
Okay, thank you, Mayor. One other area that we've been discussing and came up in the engagement exercises, Martin, was around GPs that have come back into the workforce in order to support the COVID response. Now, we've known for a long time it can be quite a burdensome process to pick up practice again, both for those that maybe have had a career break or have gone to work abroad. Any ideas or proposals around how we can reduce the burden of getting back into being a GP again for those that are hoping to do so?
Yeah, this is a really important issue because we as a system put out a call to recently retired GPs and said, can you come back and help if the crisis becomes unmanageable? And a large number of GPs did. Often GPs who'd given up perhaps early, retired early because they felt the job had just become undoable, they were unhappy with it, but they gave up their time, they gave up their retirement and came back and delivered some really important work, particularly in England in the NHS 111 COVID centre, providing telephone advice, obviously because of their risk usually related to their age. So really important contribution that they made. The question is, can we hold on to them? A lot of people I speak to who've come back into the service very purposely have only come back for a short period of time. They don't want to stay. But there are others who say, if we could maintain the kind of environment that we had during COVID, particularly with less bureaucracy, a stronger focus on delivering patient care, then actually I'd be really keen to come back, maybe for 3 or 4 or 5 sessions a week. So we've been working with government in England to try to get them to understand what could be done to do that. Partly it's about making sure the processes around getting on the performers list are easy, as painless as possible. I have to say some of the returners have not found that to be the case, but that's what we need to have. It's partly about easing the appraisal process. We can't just say that as an older GP you don't need appraisals, because appraisals, as Mayor has described very nicely, can be a very positive, important, formative experience. But there must be ways of reducing the bureaucracy associated, which will make it easier for them. Partly it's about giving them a kind of portfolio career. So if a GP were to come back for 4 sessions a week, maybe 3 of those sessions would be clinical, frontline patient care, and the final session might be supporting the younger generation of doctors coming through, providing mentorship and support for them. So I think there's a range of ways in which we are talking to policymakers to help them to make general practice a continuing attractive job for people towards the end of their careers.
Okay, thank you. We've started to have some questions come through, so I'll just turn to those in a moment. But if I can just remind people, if you have a question for the panel, it's hashtag RCGP Live Together on social media, or you can go onto the RCGP online members forum and ask your questions there. We've got some members of the team scouring that to make sure we don't miss any questions on there. So if I can move to the first one, it's going back to technology, and it's around relationship-based care, and it says, so for a huge number of us GPs, knowing your patient and having that personal relationship with them is a really important part of what we do and how we can help. So do the panel think that technology means there's a trade-off against relationship-based care? And maybe, Mayor, can I put that to you first, please?
Yes, I think speaking to people who've been doing remote consulting and telephone consulting for a while, there is a fall off where it becomes a bit less effective the less well you know your patients. But we've heard tonight that there can be great continuity of care because you can ask your patient to e-consult you in a few weeks to give you an update. So I think we have to be careful that we don't overindulge in technology and we don't forget the face-to-face consultations and the importance of a human relationship. We talk about the importance of touch, but we're not supposed to touch anybody in these COVID days. But there is an importance about having a personal relationship with your patients. And I think that stands you up in good stead then for using technology to promote that. But it's important as teams that we have continuity of care and that we do practice relationship-based care with our patients.
Okay, thank you for that. And I think one of the assumptions that people immediately jump to was the fact that it'd be really hard to do remote consultations or telephone consultations if you didn't already have a trusting relationship with your patient. One of my jobs at the college is I'm lead officer for research. So we've reached out to academic colleagues across the country, and there's a really broad spectrum of opinion. And some people think you really can build up those meaningful relationships, trusting relationships very quickly through remote meets. If I can ask you, Lawrence, how do you think this whole trade-off between needing a relationship with your patients before you start going to remote tools, or that you do have an ability to build that up as you start working through this mechanism with maybe patients that have just joined your practice?
So it's a very interesting topic. So it is, and actually speaking to a lot of our colleagues, what some of them are telling us is that they really miss their patients. They really miss that contact. We were speaking to the Health and Care Board last week, actually, and they were able to give us some initial statistics about Accurix video consultations. So in Northern Ireland, at the height of the pandemic, this is a very rough figure, at the height of the pandemic, there was approximately 1,000 video consults per week with Accurix, and this has now dropped down to about 400 per week. So we're wondering whether this is patients or GPs and the patients want to see each other more. We wonder maybe is it reflective of people's fears, and people were afraid to come into their surgeries at the height of the pandemic. So there's a lot of interesting things there. But I agree with Mare. I mean, that having that relationship at the start really makes it feel safer, and it makes it a more focused remote consult, definitely.
Gary, you're muted.
Sorry. So apologies. It was going to be someone, wasn't it? And it had to be me. I do apologise. So what I was saying is that you touched on earlier, Alistair, the importance of having the patient record available when you're consulting. And we know that we've now got an increased level of that. So we've got the informational continuity, even if we don't have the personal continuity. And I just wondered if you had any reflections from your new system of this e-consult of how difficult it is if you don't know the patient, but then how having access to their record balances off against that.
It's a difficult challenge because you meet new people almost every day. Although I've been here for 26 years, particularly in our country branch surgery, I still get the odd patient who says, "Oh, you must be new," because I've never seen them before. And I always find that very amusing. But in the electronic format, you actually do form a relationship. So if you have the consultation as an e-consult, you read all the information, and there are times if I don't know the person, I will probably phone them. But it's quicker for me because I don't have to spend a longer time getting all that information that they've already kindly supplied. So I'm then able to phone them and speak to them. And I had a very good example of this just this week, where somebody had an ongoing problem, and they'd actually spoken to my colleagues. They had supplied information, and they had sent me a photograph, and I thought I had to phone them because actually what they had reminded me of another rare case that I had with this person. So I phoned them up, and I was able to very quickly form a good relationship with them, and I'm actually following them up tomorrow to see how they're responding to therapy. So the other thing I'd like to say about this, because it tends to be a little bit quicker than doing long, in-depth phone conversations, which are quite exhausting, it enables you to have more time elsewhere. So because we're doing this, which is a wee bit slicker because we can read the consultation and reply electronically, it does free up time. So I've had the luxury of being able to do much longer palliative house calls to patients who needed the time, particularly when I was speaking to a patient where we were deciding about the withdrawal of certain aspects of care because he felt that he had reached the end of his road. And I was able to spend, obviously wearing appropriate PPE, a good deal of time with him and his spouse to be able to reach a decision. And I didn't feel the pressure of having to rush to get back to see patients. So there is little gains there as well. So like all these things, if you use it well and sensibly, it works, and it does enable in other areas. But I think if maybe someone who wasn't as experienced as me, they might find it more challenging.
Okay, thank you. And I've made sure I've hit the unmute button this time. I just want to move us on to the third area there, cognizant of time. And I think it's fair to say that the COVID-19 outbreak is probably the most significant public health emergency certainly of my practicing lifetime, and hopefully of all our lifetimes. But it has raised the question of what the public health function of general practice should be. Now, we know that the public health function was moved from health into local authorities, but general practice has, as we've said earlier on the call, really settled at the heart of communities. And we know that providing good healthcare is much wider than prescribing medication. There's so many other wider determinants of health that we can help influence. Martin, can I just ask you to give us your view on where you think the public health model of general practice should be going? Because there's got to be a golden opportunity here, because I think that the public really have started to understand the concept of population health and the role that the public health and the wider determinants can take in keeping our health and well-being where we'd want it to be.
Yeah, I think this is a really interesting and really important area for general practice. I actually don't like the words public health or population health. I use the word community health, because I think as GPs, we're used to serving our communities as well as the individuals within our communities. And many GPs historically have put a lot of effort into looking after their communities and making a contribution, going into schools, for example, working with local police, a whole range of different areas. So I think this is an area of potential growth. Of course, the role of the GP will evolve over the years, as it's always evolved. And one of those areas that it could evolve into, I think, is building this public health role. Now, the reason I think it's really important is because we know that only about somewhere between 10 and 20%, depending on how you measure it, of our health is determined by factors that we can do something about in the health system. So 80 or 90% of our health is determined by social determinants. That's our education, it's our employment, it's inequalities in our local communities, it's the nature of crime, it's a whole range of different factors that impact on our health. So the question for me would be, why as doctors would we only want to focus on 10% of areas where we can make a difference when we could play a role in the larger part? Now, some people will criticize that and say, well, I'm not trained to deal in the wider part, or this is the area that I really need to focus on, and I simply don't have the resources or the time to get involved in other areas. But we see lots of examples of practices around the UK that have got involved in their local communities and are doing things like playing a much bigger role with their local public health bodies in population health planning, who are dealing with health inequalities very explicitly and in a very planful way. We see a large number of practices that are getting involved in social determinants of health and health inequalities, particularly the deep end practices that arose in Scotland, but now are spreading across England as well. We see a number of practices that really get involved in utilising their community assets. In East London, we've got an amazing practice which is called Bromley by Bow, which has become a bit of a place of pilgrimage for people, where the starting point is about educating people, making them literate, health literate and generally literate, helping them to get jobs, helping them to improve their communities, particularly around crime, for example, going into schools. All of that stuff comes before primary healthcare service comes in. So I think there's an enormous amount of things that you can do, many of which are happening already. And one of the things that we want to do as a college is shine a light on them, so that others can experiment with them, see whether it helps what they do, see if it improves their professional satisfaction. So I think it's a really exciting area.
Excellent, thank you. And one of the things around community health is obviously it doesn't just involve the statutory health bodies as well, but also social care and empowered communities. Now, we had a fantastic response to the call out for volunteers to support the NHS through the COVID response. Have you got any plans up in Scotland, Alistair, for how you might be able to tap into the resource that is the volunteers, and how you can strengthen communities to help them look after themselves?
Well, community engagement and public understanding of how the health service work is a key aim that we have in RCGP Scotland, with our calls, which predates COVID, and what we've been calling a national conversation with how people better access and use the health services, coupled with our previous CMO's realistic medicine agenda. And this also dovetails nicely with Carrie Loonan's fantastic work she's doing on health inequalities. You know, she works in a very deprived area of Edinburgh at Craigmillar, and the challenges that she faces every day are completely different from the ones I face in my very middle class practice. Locally, it has been fantastic. On the first couple of weeks of lockdown, I had conversations with our local minister. Through our practice, I represent us on a local community trust. So the mobilisation of volunteers to help deliver medicines, deliver meals and things, that was fantastic. And through our patient participation group that we have, and I think that's a good vehicle that you can do this kind of thing. You can capture that spirit and use these people so they feel that they can go on and be engaged, and also not only help in a national emergency, but also help the local communities. And if you get that kind of buy-in, then you begin to have that role, which is what we could say is public health.
I think one of the things that's come off the back of COVID-19 is an understanding that the people living in the most deprived areas perhaps haven't done so well in terms of outcomes from COVID-19. So I was just wondering, up in or across in Northern Ireland, Lawrence, have you noticed any areas that you could potentially go in for lobbying government about getting doctors into those sort of under-doctored areas? Because obviously it's really important that we have a primary care presence, and especially in those areas that are underrepresented and are probably where they need it most.
Yeah, so Gary, in Northern Ireland, one of the big things that we're keen to push is the multidisciplinary team model, MDTs, and this really supports a practice, and it takes it back to community practices that Martin was talking about and how we can support our patients and communities. Part of that rollout would be a social worker model, and again, that can really help with deprived areas and also areas that are experiencing difficulty in recruiting staff. In Northern Ireland, the west of the country would find it more difficult to recruit GP staff. So support to them through a social model would really help with that. And again, it can be more proactive. It can be really getting into the communities and finding out the resources that are already there. I mean, I don't know half of the voluntary sector bodies that help support my community, and to have somebody who can link in seamlessly with them is a real help. The other big thing in Northern Ireland that we're pushing for hard is for equality of academic opportunities. So in Northern Ireland, we haven't had very good opportunities for GPs to be academics, to have opportunities to do PhDs, to do lifelong research models. And from COVID, our Department of Health is realizing the importance of general practice through our flu spotter practices, through participation in national trials. All these things have been brought to the fore and really made it worthwhile and shown that investment in general practice benefits our whole health.
I just want to jump back to Alistair quickly, because we've just heard about the community link workers there, and I think there's a particularly strong role for them up in Scotland, Alistair, when we were talking earlier.
So this is something which that came out of the deep end practices, because a lot of the issues that are raised are sort of social problems and people just not knowing where to start. So these workers are often from a social work background or have worked in the third sector, and they're embedded in practices, and they help patients navigate their way around systems and who to go for in the third sector for help. And also they can help enable and empower people, and they have a role in patient advocacy as well. So many practices in Scotland have them, and the aim is to get them in all areas. And indeed, even our practice has one, although we have a relatively prosperous population, and they have been very useful. I had a phone call 2 weeks ago from someone in deep distress, overwhelmed by everything that's happening with COVID, shielding sick relatives, and the link worker was able to put them in touch with huge numbers of people to get immediate help on the ground, and it was a very positive thing. So it's a really useful thing, and we hope that continues to be rolled out, and I would thoroughly recommend it. It's a very useful service.
Okay, thank you. Mayor, I'm going to come over to you and just ask you about one of the other calls that was heard through our engagement process, and that was around additional training for GPs and their teams around sort of patient motivation and coaching, really to get patients more engaged with self-care, and particularly increasing around physical activity. Have you got any thoughts about how you might achieve that in Wales?
It's something that we have done in the past in Wales. I'm not sure that there are any programs at the moment, but certainly motivational interviewing is something that Professor Steve Rolnick was very keen on in Cardiff University. And he worked with a lot of the GP training schemes, helping GPs and GP trainees learn rapid motivational interviewing techniques, mainly built around helping people to stop smoking, but they're techniques that I've used for other aspects of behaviour as well. So I think it is something that's very important, but I'm not aware of any particular schemes in Wales. Maybe we should take that back.
Okay, thank you. One thing I just want to touch on quickly, because we had a question about it earlier on, Martin, is obviously we're training the next generation of GPs, and their education process, their training program has really been turned on its head. But we've had some really good progress with designing the new exam. Have you got anything you can just mention briefly on that for us, please?
Yeah, so people, I'm sure, will be familiar with the fact that the clinical skills examination that we used to run, an important part of the tripartite exam that we organise, was cancelled because of social distancing. So we have been designing essentially a blast from the past in some ways. It goes back to using videos in which trainees record for themselves and then submit to be examined against a set of criteria. The exams team in the college has really worked incredibly hard to develop the system over a very short period of time, so that the 15 or 100 or so trainees that might have had their training delayed as a consequence of COVID are still able to sit the exam. We've received a large number of videos that have come in now. The examiners are going to start examining them tomorrow, if I'm correct. So we're on track to assess those videos that have been submitted using technology run by 14 Fish, which many trainees are familiar with already. I think it was a necessary move and an exciting move. It changes the nature of this component of the exam from something that was run in London to something that can be done within your own practice, and a lot of people will like that. It is still an experiment. We don't know what it will look like. We're going to be doing a lot of work to further develop it, but it's likely to be in place for at least the next year and maybe longer.
Okay, thank you for that. So we're drawing towards the end now, and I think just quickly run around the panel for that 30-second answer. What change have you experienced personally over the last 4 months of practice is the one thing you'd want to retain in the way that you provide care for your patients? And I'll start with Mayor, please.
Oh, now that's difficult because I've retired, so I don't actually see patients, but I'm very closely in touch with Peter, who's my joint chair. And I think the thing that he has really enjoyed has been the telephone consultations. I think he's found that that's been a really useful way to keep in touch with patients, particularly patients who don't want to come to the surgery, and a good way to keep in touch between consultations.
Okay, thank you. And the same question for Lawrence.
So I think that the improved interface with our secondary care colleagues, we've had some fantastic teaching opportunities through GPNI website, and just a feeling that we're sort of working together and really good support with GPs asking informal questions using CCG, email software, to get questions about clinical conditions. So it really has improved our clinical interface.
Excellent, thank you. And I'm glancing down at the mute button to make sure I'm not making the same mistake again. Over to Alistair, please. The one thing you'd like to keep hold of.
Having coffee with my partners for the first time in many years. It's been a huge silver lining of COVID that suddenly the workload pressure is off and I'm able to sit down with my colleagues every day and have a cuppa. It's been great.
Okay, thank you. And I'll give the last word to Martin, and not just because you're my boss, but maybe you just want to sum up some of the changes that you're going to be really fighting for on behalf of the profession through your role as chair of UK Council.
Well, there's a range that we're fighting for, but I think one of the most interesting in terms of potential is digital triage. And Alistair referred earlier to the use of e-consult. There are other forms as well. If you've got supply that exceeds demand, and patients often aren't quite sure who to access and how to access them, then using digital triage to help them to make those decisions, so it's kind of patient directed and patient learned. I think we've got a long way to go to make it really effective, but I think it potentially adds an awful lot to what we're doing. It helps us to address the workload issue so that we can then put our resources into delivering really high quality care for those who will benefit most from it.
Excellent, thank you. And I think for me, the biggest thing is that we've been given a whole host of new tools that we can use to consult and care for our patients. We're still in the very early stages of working out the full potential of those, so it's really quite an exciting time with being able to do things in a different way in partnership with our patients. I just want to say a big, huge thank you to the panel for coming along tonight and supporting this discussion, and to say thank you very much for everybody who's tuned in to watch this live, and for those that are watching on catch up. Don't forget that we have our COVID resources page on the website. If you want to keep up to date with what we're doing around COVID, then that details of all of that is on there. The next one of these sessions is on the BAME workforce and the COVID-19. That's going to be chaired by Margaret Ikpo, and we've got a fantastic panel lined up to answer your questions on that evening, which will be the 14th of July. So once again, thank you very much to the four of you for coming and discussing things with me tonight, and for all of those of you out there that are listening, thank you and enjoy the rest of your evening. Thanks a lot.